Hello, Dr. Jang. Would you please show your case?
Okay, I'm Yangsoo Jang from Yonsei University, and my colleague, my team is Dr. Byung-gu Kim is just right side of me, and Dr. Igarashi, Yasumi Igarashi Sensei is looking and teaching us to
no.
procedure, and Dr. Ho Osumo from Gaimyeong University is here to explain the imaging for this CTO intervention. First of all, Dr. BK Kim will introduce this case. BK, please.
Okay, welcome to Yonsei Case Rep. So let me introduce our case. This CTO patient is a female, 64. Next slide. Yes. His chief complaint of the exhaustional chest pain. On past history is that she underwent DS implantation because of the RCA CTO reason. The stent was Endeavor stent. And on recent BB scans, the moderate size, the reversible defect in the inferior lateral wall was noted. On echocardiogram, severe hypokinesia was noted. LV ejection fraction was normal. Next slide. This is the prior PCI NGO. So as you can see, the really subtotal reason was noted in middle to the distal RCA. So we put the 2 Endeavor stent implanted. And next one. So because of the recent aggravated dyspnea, the coronary angiogram was performed. So this is the coronary angiogram. So the prior implanted RCA stent was totally occluded with 100% instant restenosis. As you can see, the other vessels was quite normal, quite so good, and also the collateral channel was well preserved. Yeah, this is the finding of this case. Next slide, and we also performed the CT scan. Next slide, please. Next slide.
CT?
Yeah,
okay.
as this is the CT scan was she undertook. So as you can see, the end of the stent was totally occluded. The reason was noted. Even though there was no calcified reason was noted, and also as you can see, in the stent area, some contrast was noted. It means some microchannels could be possible in this CT scan. Yeah.
Okay, thank you very much. And let's see the angio that we took today. This one?
오늘 찍은 첫.
This one?
Yeah.
Yes. As you can see, we are preparing the bifemoral approach because the CTO segment, even if the instant stenosis is very long, including the distal stent CTO segment is relatively short, like 10 millimeter or not, or less. But the ISR CTO is very, very long. So I think the back and forth of antegrade approach as well as the retrograde approaches should be good. So we choose the A French implant, short tip for the right coronary angio, and Hyperion 7 French HP 3.5 is for the left coronary. Next. This is the areocranial view. You can see there is an interventional collateral from the first and second septa, looks like. Okay. So what can we do from the panel?
Next technique, yeah.
Now this is the epicrania.
Is there a reason that you use 7 French to the left system?
I cannot hear you. Say again.
I said, is there a reason to use a 7 French catheter to the left system?
마이크를 여기서 들리게 해주면 안 돼요.
For standby for retrograde approach.
Right. 8 French, right.
No, on the left system.
On the left, 7 French.
He's using 7 French.
System is 7 French and the right system is 8 French. I think for bilateral approach, this guiding size selection is very standard style, I think.
But if you consider retroid approach, you'd better choose 8 French for left.
No, I don't think so.
Because of
usually,
backup.
Sometimes.
Yeah,
However, this case is interventional collateral route is not so tricky. So maybe 7 French guiding catheters is
Would be
enough,
okay.
I think. But my routine practice for retrograde route, 7 French guiding catheter is usual side. I
지금
think.
아무도 말을 안 해.
8 French guiding catheter is not always necessary.
I have many experience of CTO intervention with retrograde approach. In those cases, sometimes it is failed to pass microcatheter through narrow septal channel. Thus, I always mandatory use retrograding catheter 8 French with strong
you
backup.
prefer.
Okay, in such a situation, my style is I use side branch anchoring for retrograde approach to enhance backup force. So my feeling, 8 French guiding catheter is not always necessary, I think.
So what's your approach here? Antegrade or retrograde?
Okay, his question is, this case is antegrade or retrograde?
Oh, okay.
Ante first
Please explain.
and PRN
I think
retrograde.
the antegrade approach, you may need a very, very strong backup. But I'm not sure that this 8 French guiding can provide that kind of strong backup. Dr. Igarashi advised me that if we have a M plus 1.5 or 2 with a short tip, then 1.5 and 2 is a bigger second curve, so that will provide a good backup force against the LT wall. But unfortunately, we do not have that kind of M plus guiding. So we just select left M plus 1 with a short tip. Any other? I think the integrated approach we should try, because the distal stent CTO segment is not long, but as I told that that only we can have enough space in the ISR CTO segment. Then that short segment of distal stent CTO will be easy, but we don't know yet. But,
I think there are at least 3 favorable factors to support antegrade approach, because proximal stump is good. Second, we can get insight regarding the CTO segment by stent struts. The third is, when we consider the history of recurrent angina, it is not so long. Thus, I can think antegrade approach may be successful.
Good. Good suggestion.
We hope so. We hope so.
If you do not any comment, I'll explain the next procedure. Next. So, because the broadcasting is mainly from the TABI, so we want to show the integrated approach to you. So we just start the retrograde wiring to just prepare the retrograde approach. So this is an injection, and there looks like a channel, but not clear. So I changed another angle. Next. So we can see clearly there is a micro channel, interventional. Next. Next. So this is SO 03. There we go. For the microcatheter, I choose the Carabel because just approved from KFDA, and it has a wide lumen, even though it has a low pushability. Next. So SO 03 easily go into the distal RCA segment. Next. 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 The caravel goes very well. But as you know, the pushability of caravel is not good. Next. So after positioning this caravel, we just close the Y connector and start with the integrated approach. 환자 좀 누가 볼래? Next.
한 명은 환자 옆에 있어. 환자 좀 봐주세요.
Next.
What is the ante-wire?
Now this integrated wire is UB3. 뭐래?
아닙니다. 괜찮습니다.
Next. As you can see, the guiding catheter is flipped down. So we decided to use the anchor balloon. Next. So we anchor with a 2.0 balloon with a 2 AM. But next. Next. But during the procedure, the anchor was flipped down too. So we decided to use the other wire. Next. 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 Like this. So this is the Igarashi Sensei suggestion. The wire increase the resistance of the balloon flip down. So provide a more supporting strong backup. Next. So the distal, this is array or caudal view. Even though now the wire is Gaia third.
Third and concussed.
And no concussed. Gaia third.
Gaia third, yes.
And that corsair cannot pass through that position. Next. So because of the backup is not enough, or the fibrotic tissue is too strong, so we decided to do the balloon. This is 1.5. Which balloon? Tatsuna?
이카츠치 zero.
Tatsuna and Ikazuchi.
But we cannot go into the
mid to distal.
mid to distal ISR CTO. Next. 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 So even though wire is in the distal RCA CTO, in the stent, not go to outside.
Inside.
Next. So we repositioning the anchor balloon again. Next. But as you can see, the balloon cannot pass.
Right wire.
And this is the now next step we can do is that mobilize the retrograde wire. So because of the CTO segment itself is relatively short, so I think we may easily go into the stent space, but this is UB3 that we have used in the integrate, but not easy. Next. So we changed to the Miracle 12. It looks like in the stent. Next. Next.
Now,
But now it's going to the outside. But caravel, we cannot advance more. So what I'm going to do right now is the anchor trapping the retrograde wire, and I'll change it to corsair. So any question or any suggestion?
Antegrade wire is Miracle 12. So retrograde wire is
No. Retrograde is miracle twirl.
Retrograde wire is miracle twirl.
Retrograde is miracle twirl.
Right.
Anti-wire,
It's currently this wire is Gaia third.
Gaia third, okay.
Yeah.
Gaia second.
No. Anti-grade one is Gaia third.
Okay.
Yes.
Confusion.
So many CTO wires. So we also confused. So many choice. So we must understand the difference of performance of each guide wires.
이래요.
So it is surprising that there is no calcium on the CT scan, yet you are having trouble with Gaia third.
Usually in the ISR CTO, the calcium sometimes you can see, but many of cases you cannot see the calcification. But the fibrous tissue
Yes.
in the instant
It's occupied. Yeah.
is packed. So a lot of this are more resistant than calcium, I think.
The problem
And
now,
And usually, and some de novo CTO case, also the tissue without calcium in the CT, sometimes it's very hard to manipulate. That means that not only calcium, the fibrous tissue is also the big hurdle. Now I think the patient complained the vasovagal.
Maybe vagotomy?
No. 아트로핀
몇 개 들어왔어?
에코 좀 가져와봐.
에코브 주세요.
에피네프린 줘.
can you see the hemodynamic profile?
Now blood pressure is 60.
70, 60. Between 60 and 70.
아트로핀 줬어?
아트로핀 더 주세요.
에피네프린 줘.
Is the
또
right
뭐야
guy
이게?
deep?
믹스한 거?
Okay, gradually increasing.
네. 볼륨부터 주세요. 네, 조금씩 나아져요. 네. 저어보세요. 환자분 저어보세요. 네. 심호흡을 천천히 하세요. 네.
Okay.
Now our pressure is 80.
Okay, looks good. And global ejection fraction is not so bad. So hydration.
62.
Hydration.
볼륨부터 좀 주세요.
I think the position itself looks good.
Yes, I think so. So let's try to advance retrograde.
Yes, I advanced.
Corsair.
This why a little bit more.
A little bit outside. It's okay. 네.
I have experienced that Miracle 12 is the final kind of a saver of such kind of difficult situation. Thus, please consider the Miracle 12 when you encounter the very difficult situation. In this case also, Miracle 12 may solve the problem.
조금만
Uh,
Impossible now.
Because you used the 7 French guiding catheter. If you used 8 French, it may advance.
You're very right. But this is a Hyperion, so I think I'll try.
A little bit.
Advance.
네.
Professor Hyoso Kim,
Yes.
I disagree your opinion because currently guiding catheter, retrograde guiding catheter tip position is very stable. If backup support is very weak, guiding catheter position is easy to back to aorta. However, in this situation, guiding catheter position is very stable. So, guiding catheter related, not guiding catheter related problem, I think.
I think
So, 7 French or 8 French is not essential problem in this for this patient situation.
If the left main is a kind of disease, then I did not meant to use 8 French. But in this case, left main is really good. So why not use 8 French? It's a little difference can determine.
That is your style. that is your style. But I want to point out, letter root is usually 7 French is a standard. But
Okay.
I think
And
it's
now
almost
crossed.
in.
Yeah.
not crossed.
I
Advance
think
inside.
한명 붙어 있어 봐. 2mm만 드려.
왜?
You made some
통증이
progress.
조금. 네, 환자분 눈 떠보세요. 네, 지금 아주 잘 되고 있거든요. 조금 참아주셔야 돼. 지금 우리가 다 잘 되고 있는 건데. 아직 한참 있어요.
Not that.
그럼 아니면 수술하셔야 돼요.
Okay, maybe I think one stroke outside.
One stroke.
One stroke outside.
Two stroke
I
outside
think.
and inside.
So let's change guide wire.
Guide
Put
wire.
back and try again.
Yeah, a little bit pull and redirection. Okay,
Yeah.
not outside.
Different channel.
This is unbelievably hard. Not controllable. Do not rotate.
Change the wire.
Gaia third.
가야 써.
Another one.
가야 써드. 가야
The
써드.
pain 있어?
조금이요. 네.
세로죠.
써도 줘.
You want?
뺀.
Usually, ISR CTO is more easier than de novo.
My impression, very easy or very difficult. No intermediate. Usually, such a kind of a very long
Okay.
RCA CTO is very difficult.
Please check another angle.
Yes, yes.
Let's go to area
Slowly,
powder.
yeah.
아래 커더.
봐줘.
Okay, different route. However, two right.
At the tip.
However, entry point is maybe different. So,
예. 카우달 좀 져볼까요? 카우달 아래로 조금 더 주고 카우달 더 주세요.
okay.
Yes, okay, good.
Okay, successful.
Store.
Not yet, not yet.
Not yet.
No success. Yeah.
Okay.
No difficulty from now on. Yeah.
Left. Area.
약간. Cautiously.
조금 바깥.
Okay, let's try to advance microcatheter inside of CTO region.
So why not advance the antegrade wire and do high inflation with the small balloon so that you'll create some dissections within the stent, and then you can advance the retrograde wire.
Start reverse cart.
Yes. We are considering that technique.
More advanced.
We just want to advance a little bit more. The retrograde catheter, microcatheter.
Advancing?
No, a little bit advanced.
A little bit, I think.
Outside.
Okay.
Microcatheter advanced.
Yeah, advanced. Nearly approaching the end of the stent edge.
I think so.
Okay.
Reverse cut in the distal segment, you mean?
Yes.
Okay. Anyway, I recommend to advance more until more proximal part of CTO region.
The tip looks outside. Broken? Or? Let me check. Area.
Okay, anyway, let's try to advance microcatheter more deeply. So,
Not
if
move.
you advance, no move. No move, okay.
That looks okay. Area. I'll try a little bit more.
We have 17 minutes.
17.
17. Just show us reverse wire enter into anti-guiding catheter. That's the end.
However, that is still very long way. Yeah.
Yeah.
Oh, okay. Very nice. Very nice. So if so,
Changing.
okay, let's change to the UB3.
UB3.
Yeah, it's better. Okay, very good. Yes. Not necessary to use.
What's
And
the,
another option is knuckle wire. Knuckle wire is better.
what's the UB3?
UB3
Ultimate
is slippery guide wire. And to control is better.
How much is the tip load?
3 gram.
3 gram.
Yeah. Not so heavy.
It probably is not available in Korea.
No. Available.
Frequently.
So many years ago.
UB3.
Yeah, ultimate.
Ultimate broth.
Ultimate broth. Okay.
Yes.
UB3.
Ultimate broth 3 in Japan. UB3. UB3.
We call it ultimate broth. Yeah, okay.
But you call UB3.
Yeah, UB3.
But doctor by doctor different. Same one.
This is not moving.
Okay. Anyway, around this point very hard.
Right. Hinge point.
Yeah.
Okay.
Yes.
Let's move
This hinge point
one.
is very hard.
Now,
So let's escalate.
다시.
escalate.
No, No advance, escalate.
Retrograde wire?
AU guide wire is okay, maybe. Because central SATA is very good guidance.
Yes.
Of course, more to controllable and low tip load guide wire is of course safe.
디발론? 네.
디발론 했죠?
디발론 되어 있습니다.
Compared with antegrated wiring, this microcatheter position is more stable and more strong back support. So usually more easy to advance. Professor Hyoso, I completely agree with you.
For this one,
I never start antegrated wiring without stable backup support in CTO PCI. Okay, guide wire advance.
I think it's almost kiss.
Okay, but inside of the CTO region. Okay, next step is we must decide reverse cut point. Reverse cut. But actually, antegrade microcatheter or balloon catheter cannot advance more distal side. Reverse cut point must be this point. This point.
Distal.
Distal is better. However,
balloon is not pass.
No advance.
No advance.
Antegrade microcatheter.
That's the problem. Actually, I tried to knuckle wire from the retrograde wire, but this knuckle cannot move forward. That means this angulation part is very, very heavily fibrotic tissue.
Okay. Anyway, I think antegrade microcatheter delivery is difficult. So we must advance lateral wire more proximal. So let's try another technique. So please open pilot 200. Pilot 200.
Pilot?
Yeah.
100?
200. 200.
For retrograde knuckle.
Oh, okay.
Simply.
Okay.
너커, 포 너커.
Yes.
Yeah, pilot 200 may be a good option.
그냥 파일럿.
포리마 자켓.
그냥 파일럿. 우리
Pilot
심플 와요.
200. Pilot 200. 15. Okay, please open. And sometimes Gaia, SAD, or such a kind of knuckle is very useful. And
Gaia?
Yeah, so many choices. Still, we have so many choices. Of course, Conquest series is another option. This is Pilot 100, 50.
Just 50. 150.
팁.
Go outside.
Cautious.
Outside.
Cautious.
Outside. Okay, please make intentionally knuckle shape.
No, pull back your.
To stay inside of CTO region.
Okay, yeah. How many minutes left?
7 minutes.
outside.
Probably outside.
더 지금 콜세오 TV 살짝 아웃사이드로 나와야
Go
돼요.
back to Corsair.
Really?
네. 그렇죠. 네.
Okay.
오케이, 굿. 스톱.
Okay.
스톱.
Okay, more healthy. Healthy wire is better. And maybe already.
Yeah,
Almost in.
almost, yeah.
Yes.
Go area.
Wire change. 뭘로 바꿀까요?
Let's change wire.
오케이.
Workhorse wire. Let's change.
와이어 뭘로 둘까요?
Gaia.
Second?
We have Gaia second.
No. Floppy wire is better.
프로피 와이어.
Already this part
okay,
is successfully maybe connected. I think.
런스루?
Run through.
소프트 와이어. 아까 뭐였어? 시용?
Let's try first. 시용.
시용? 시용 블루. 오케이. 시용 블루. Yeah.
And the next option is UV3. 3. Broken. Okay, all right.
For the technique of knuckle wire, full metal jacket wire, such as pilot, is definitely better than ultimate bronze, non-coated wire.
Of course.
Yeah.
For knuckle wiring, polymer jacket wire is more better. Today we use pilot to 150. However, I recommend to use pilot 200. Tip load is around 4.5, not so stiff one.
How often do you check the ACT in these long procedures?
Just
ACT?
beyond
30
1
minutes.
hour,
Every
then
30
we
minutes we are doing.
repeat ACT.
1 hour.
Beyond 1 hour.
1 hour? Not too long.
The first time check the 1 hour, and then every 30 minutes we check the ACT. After that.
I think there's
No pass?
not pass.
Still inside. If so, UV3 or such a kind of not so
UV3.
stiff wire is better.
이걸 좀 뺄게.
Okay, 1 or 2 minutes.
UV3?
UV3 new one. Because
UV3 new one.
Live transmission is a few minutes remaining. So you must pass.
UV3.
So new one is better.
팁. 옆에 나와 있는 거 시온 블루.
Nowadays, Korean interventionists are really hard time because government will strictly cut the usable number of wire and balloon. Just 3 balloons for CTO bifurcation, just 3 wires for CTO. So really hard for us. Yeah.
Hyoso Kim, in Japan, similar situation.
Really?
However, this is a live demonstration course.
They change in Japan.
I knew there is no limitation in Japan.
No. Current situation is dramatically changing.
So now I handle wire very gently to avoid tip disformation, to save the number, to limit the number of used wire.
So in India, they reduced the stent prices. The government mandated stent prices are reduced. So now we can use more new wires.
Oh, really?
Before, the wires were actually sometimes reused. In the United States, actually, CTO is reimbursed at a higher rate.
Very hard.
Reverse cut over there.
Yes. Reverse cut is better. Reverse cut is better. Unfortunately, no time. However, reverse cath is better.
It's time to do anti-ballooning.
Yes.
Okay, I'll do that.
reverse cath time.
앵커 볼륨 좀.
Balloon?
앵커 볼륨 주세요.
Okay, maybe 3.0 is already open.